Good evening and welcome to Let's Talk, a program about mental health and addiction. I'm Nels Kloster. I'm a local psychiatrist, and my co-host is Robert Stack.
Robert Stack. I'm a licensed alcohol and drug counselor, a licensed mental health counselor, and this is our first time doing this call-in show, and one of the things we'd like to do is just try and answer people's questions or concerns they may have. We're not authorities or experts or anything like that, but we're just workers in the field, and we'd like to be helpful if we can.
Right. And Robert, you and I worked together for a number of years.
Right.
And often in our work, we've asked ourselves, really, what's the main purpose of what we're doing? Why do we do this? What do we help to accomplish? And I think that one of the things that you said that really stuck with me as I've done this is the idea is to give hope.
Right.
That people are struggling and suffering, and if we can give them some hope and support, we can't ask for much more than that.
Right, and the fact that someone heard you or that someone listened to what you have to say, because quite frankly, that's all we can do is sort of listen and hear your concerns, perhaps offer some guidance, some ideas about maybe some approaches, but mostly we'd just like to hear from you this evening. And we're having some trouble. This is our first time doing it. We're having a little trouble with the text, but we do have email and we do have a phone line. So we are ready to accept your phone calls and emails, and we'll do the best we can for the next half hour. So let's give this a go.
Absolutely, let's give it a go. And of course, this is not meant to be professional advice, but offer some support and maybe some direction as people call in with what their struggles are. And so, we start off. We have an email from Sally in Wilmington. And what Sally's asking, she says, my friends tell me I have a problem with drinking. Maybe I do drink too much on the weekends, but I hardly drink at all during the week. I just like to party. Do I have a problem?
Well, in the field, sometimes we talk about people being in different stages, getting ready to change. So this is somebody who's just starting to maybe be contemplative. And the way that's happening is that other people are remarking on it. And there's probably two clues to early onset or the beginnings of alcoholism, if you will, is one, you begin to question your own drinking or start justifying, like I just do it on weekends, I just like to party. And other people become concerned about your drinking and sort of try and give you a heads up. So I would say this is perhaps the early stages of alcoholism, but it's definitely a moment to sort of reflect and take a look at what is going on. And, it won't do you any good if you make a disaster of your life on weekends and the rest of the week you do well and you show up for work if your drinking is at such a point that it affects others.
Yeah, you might find your weekend sort of bleeds both ways from Saturday and Sunday to Thursday to Monday, and eventually goes on. And I think I'm hearing sort of this voice within Sally that is thinking there's a problem.
Right.
To have even asked this question, I think, shows that there's some pretty important conflict going on about what she's doing and what she thinks the effect of it,
right.
How important it is.
And this whole idea of starting off like, I just like to party, sometimes it starts off as a party, but at the end it's not a party. And it's something else, and it's one of regrets and stuff. And so I mean, I'm glad you call. I'm glad they call in. Really, I mean, it's sort of like, well, I'm actually thinking about this, and it is something to be concerned about. It is something to pay attention to.
Yeah.
But I wouldn't make a diagnosis. I wouldn't say, oh, well, that's what it is. It does sound a little bit abusive. Sometimes when someone says, I just like to party or I drink on weekends, they're usually drinking to intoxication, and it's again, like I said, sometimes you can get into huge trouble on the weekends, and the fact that you don't get in trouble during the week when you're working is no justification for some of the things that may happen on the weekends.
Yeah.
So,
and I think that what Sally is thinking and feeling is much more important than this, but we also sort of try to put numbers to it and put characteristics to it. And one of the things we talk about, there's this concept of course, dependency or being alcoholic, which means an increasing amount of tolerance, having withdrawal symptoms, and abuse where you're running into trouble with family, with relationships, with obligations, or having legal problems. And then at sort of a lesser level is this concept of at-risk drinking, which in this case for a woman would be whether you have 3 or more drinks at one sitting at any time, or have more than 7 drinks across a week.
that's right.
And unfairly, the numbers are a little bit higher for men. But we do know that women suffer more from the impact of this, taking less time and less amount of alcohol before they start to feel the physical effects and be impacted by alcohol.
And the final comment would be that, you know, if while you're thinking about this problem, if you have a drink while you're thinking about it, that would be a clue.
That might be a good clue.
I mean, an alcoholic or somebody that headed that way would say, I'm going to have a drink and think about this.
Yeah.
And I think that would be something to pay attention to.
Yeah, definitely. As well as paying attention to your friends who obviously care about you.
That's right.
Okay. So then there's another one here from Maggie in Keene. And what she's asking is, how do you know the difference between being codependent or just plain helpful?
It's really hard. I mean, in the beginning, just about every codependent, it starts off by caring. I mean, I consider it one of the tragedies of addiction is that someone who loves you and cares about you has a really high risk to become codependent. Now, codependency is sort of misunderstood. It's really when someone's illness that you start off caring about and you're trying to be helpful to them. Sometimes you'll get enmeshed with them, you get over involved, and then you try and control them, and you try and manage their recovery or their treatment or their illness. Like how you can have beer, but you can't have whiskey. You can drink. I'll go get it, and it's sort of. But the problem with codependency is that at the end, it begins to feel like not something that the person has. It's something that's happened to them.
Okay.
So it's sort of transferred almost. I mean, they begin to feel hurt. They begin to feel angry and scared that you're going to keep using. And so I wouldn't say is it either or. I would say that most codependents start off being very helpful because they're caring and loving, and it's great to have somebody in your life that's helpful. The problem is there's no cure for it, and that over time the illness will begin to affect the caretakers, the care providers, and especially in addiction, and I'll stop with this, but with addiction, because there's that element of free will, toward the end it looks like you know how much this hurts us or me, and you keep doing it. And so at that point it becomes sort of, that's when you get into that codependent cycle where it's no longer an illness that somebody has and you want to be helpful to them. It now becomes something that's happening to you and you're powerless over to stop it. And that's really a scary feeling. When someone who you love or loves you, when they're hurting you and you can't get them to stop, I mean, that's just a terrible place to be.
Yeah.
I'm sorry.
No, absolutely. And I don't know the codependence necessarily. Is that a term that we use that you find anywhere in the literature? It seems to be a very sort of popular term.
It came out of a good purpose, because they used to say years ago when we used to bring people in the hospital, we would take a family member off to the side and say, this is a good time to get help. And their family member would say, oh no, I don't need the help, it's that guy in the other room. And eventually you would sort of say to them, and it sounds kind of crude, but you would try and say to them, listen, we think you've been affected by their illness, and we think this has hurt you. And they came up with that term, codependent. It's like a word that they made up about 25 years ago. And it became famous with Beatty's book, Codependent No More. Okay. And once it became a skit on Saturday Night Live, it became sort of useless. But prior to that, I mean, it was a good way of talking about family members or loved ones who cared about an alcoholic or an addict, but over the long-term chronic condition, they were affected by that disease. And so I don't think it's scientific or anything, but it's definitely real. I mean, if you've ever had the privilege of being in an Al-Anon meeting, I mean, it's just, to live with an active alcoholic or addict is just heartbreaking.
Right, and then you have to learn basically what is your responsibility and what do you own in that relationship. Because I think that a lot of people often will find themselves in these sort of relationships over and over again.
Right.
And as well as that very intense desire to help that person change. And some of the very basic tenets of Al-Anon, for example, are that you didn't cause it and you can't change it.
Right.
And sort of learn how to carry on by yourself and put some very good boundaries around what your responsibility is and whether you stay in that relationship or how you stay in that relationship is very important. Right. And recognizing too that it's almost like a drama or a play. People play various roles, and when you find yourself in that role repeatedly, or you find yourself in that role with your family, anybody who's going to change what they're doing is also going to change the dynamic of the relationship. And so you might find yourself snapping back into that role because it's more comfortable for you, right, as you're sort of working your way out of that role.
But here's the ultimate thing that hurts sometimes is the fact that you get really scared. You get this dilemma where you feel like if I don't help the person, they're not going to get better. And then somebody comes along and says, you know, all that help you're giving them, you're keeping them sick. And that they have to hit bottom before they get better. And that's really scary. I mean, you sort of don't know what to do. And a lot of times you'll see that with families. You'll get to a point where they say, I just don't know what to do. You know, on one hand, people say, I rescue them, I'm enabling them. On the other hand, it breaks my heart, and I can't stand by and watch them, you know, lose everything. And so what I usually suggest, and I'll close up with this, but what I usually suggest is that be helpful in recovery, but don't help them with the disease. Okay. In other words, don't pick up the pieces when they break something. Let them pick up the pieces.
Gotcha. Yeah.
But if they need help in recovery, if for whatever reason to get better, then you want to show up. Then you want to be there. I think one of the problems with some codependents, by the time they get to the end, they're so numb and so beat, they go, I'm not doing anything for you.
Yeah, because they've gone through stages.
That's right. Exactly. So you want to avoid that. You want to get to a point where you've sort of given up on the person and you're deserting them. Okay.
Okay, so we have a phone call.
Hello.
Okay. Hi, I'm wondering if you could just talk a little bit about the disease model. I feel like most people have accepted that addiction is a disease, but then I hear so many people interpret that in so many different ways, and I feel like I don't even really know what that means, especially on a personal level.
Okay. So the question that was sounded a little muffled was to hear about the disease model and how that applies to, well, mental illness certainly, but addiction as well. You know, maybe we should take a little bit through history, how this sort of started off as like sort of the idea was a moral failing or weakness of character.
Or we could just skip it and
say
we didn't hear that question. Go
ahead. Yeah. Well, and this is something we've gone back and forth too, because I think that as doctors and medicine have sort of gotten involved, more involved with addiction particularly, there's been this let's say debate and back and forth between sort of 12-step spiritual sort of approaches, and then doctors come in with medications, it's the disease, and treating it in a different way. But I mean, clearly it has very much in common with other things we consider to be diseases, for example, like high blood pressure or diabetes, as that we can see various things in sort of genes and environment that can bring this on. And when I say environment, I mean things like what's happened to you or what you eat or whether you smoke. You know, there's a very, very broad idea, this idea of sort of environmental or nurturance playing a role here. But where then there's often this tension is that some people take the disease model being to, okay, give me a pill, fix this up, and they ignore their own responsibility and what they can do as far as behavioral approaches to getting healthy.
Well, yeah, and I think that one of the things that we try to do is make it the medical model. In other words, it's not a moral issue. It's not a social issue. It's you know, I mean, it was really this idea, we want to treat it in a hospital, we need to do detoxes. It's almost the birth of the medical model. It's the disease concept. You know, and they say the 3 criteria for disease is that it's chronic, there's no cure, it's progressive, it gets worse, and left untreated, it's fatal. I think it worked on some level to get people to think a little bit differently about alcoholism and drug addiction rather than seeing it as a character or moral issue. But I think you really need to take it one step further and say it really is a mental illness. Now there's a physical component to it, obviously. There's the destruction of the body by alcohol. There's the physical dependency on the drug, whether it's be opiates or whatever it might be. But the real issue is really, the problem is the fact that even after it becomes not voluntary, even after it becomes harmful to you, you find yourself unable to stop. And at that point, we suspect, or we make the diagnosis that it's a mental illness. And it's a mental illness because your brain gives you permission to do it. Yeah. It's no longer something that's fun. It's harmful. It's destroying your life. You say you want to stop. You make a commitment to stop. And yet, invariably, your brain will give you permission to do it again. And we suspect at that point that it sort of moves into that territory of mental illness. Right. I hope that sounds right.
Yeah, no, absolutely. I think part with mental illness, and I just want to make the point that it's such an artificial idea to try to separate out addiction as being something different than mental illness. I think those of us who work in the field see addiction as a specific type of mental illness. And with mental illness as a whole, one of the things we struggle with in this field is that in the rest of medicine, there's sort of very clear sort of mechanisms and causes for things. You know, if you have a certain pneumonia, you know what the bug was that caused that. Lung cancer, for example, you know, cigarettes caused that. And it's still rather mysterious or unknown in mental illness. We're starting to find with various imaging studies, what's called functional MRI, if you've ever seen those pictures of the brain with the rainbow pattern of colors there. That's the type of test I'm talking about. And seeing that certain areas light up, certain areas have a higher rate of metabolism with certain illnesses and certain events, that we're starting to get to that point. We're trying to figure it out, but the actual sort of what structures in the brain or body are affected and what genes might be involved is still a ways off.
Right. And the thing that some people sort of forget is that when they consider addiction and alcoholism, they only think about the actual substance. So if you stop drinking, then they say, well, then you're cured. Right. Well, you're not cured. You still have the illness. You still have the illness of addiction. It's in remission. You're not drinking, but it doesn't go away. And I think that, you know, for a lot of people, and I'm repeating myself, but the whole issue around free will is so difficult to understand. Like if someone committed suicide, I mean, you would just be, oh my God, why would they do that? Why, you know, literally, and you would say, well, you know, what were they thinking almost?
Yeah, how could they do that to me?
How could they do that to themselves, or how could they do that to us? And what you don't realize is that their brain gives them permission to do it, and they have free will, which is why it's so hard to prevent suicide. And the same thing with addiction. They have an illness, their brain gives them permission, just one more, just today, won't hurt anybody, you know, this time it will be different. And they have free will, and we can't stop them. And so from the outside perspective, it really looks like willful misbehavior, which is, I'm borrowing those terms from the Supreme Court. When the veterans put in for disability, service-connected disability, the Supreme Court studied it, and they did not award them disability. They said it was willful misconduct. Okay. And so there's still that element between, on one hand, we see it as an illness, and yet for a large part of society, they judge it as a moral decision that people make. All right?
Right. So we have, it looks like we have another email.
Okay.
And so this one, this comes from Lucia in Marlborough. She's writing that the term bipolar is used very freely. And she's wondering, you know, just what is bipolar disorder, and is medication necessary for this?
I'll leave that up to you.
That sounds like my line. Yeah, no, absolutely. I mean, there's been a lot of research into bipolar disorder in the last decade or so, and not just in adults, but in children as well. So I think that one of the things you see is when there's a lot of interest or research in something, there's a lot of press and publicity, and in that case, it was very popular. So I think that, you know, it's almost a joke, I guess, not a very good one. If you go see enough psychiatrists, you can eventually get diagnosed with bipolar disorder. Now, the idea of, you know, classic bipolar disorder is what used to be called manic depressive disorder. So meaning, in this case, two poles, the one pole being depressed and the other pole being mania.
Right.
Now, mania, if you want to think about sort of classic mania, sort of full-blown, you know, no questions asked, this is mania, this is bipolar disorder, people don't need to sleep anymore. They're getting by on 2 or 3 hours of sleep a night. They have a high level of energy. They're trying to get many, many things done. And their speech and their thoughts are just going so fast, it's hard to sort of slow them down and have a conversation with them as well. And they get these sort of what we call grandiose ideas about themselves. They think that they have some special powers or some special ideas. When I was in my training, one of the most, I always say when you find somebody, your first patient you meet with a certain illness, you always remember them, and they become sort of the hallmark for the future there. And this guy, he came into the hospital because he got pulled over by the police. He was driving 100 miles an hour down the highway, and he was heading for D.C. because he had something very important to tell the government back at that time. And when they went to his home to pick up some belongings for him, the place was a mess. And he explained that he was piling books and papers all over the place. he was having this replicate an archaeological dig in Egypt, and he was at work on his computer. He was inventing a new language because English wasn't fast enough for him. So that's, no doubt, that's mania. That is out there, and this guy was thinking he practically sat on the right hand of God. Then, of course, it's followed by a terrible crash and depression, which then has the two poles, and almost invariably, the mania gets followed by depression. But then people who are just difficult with their moods, they're very change very much throughout the daytime. They'll get labeled as being bipolar as well, because I never know where you're coming from. 1 minute you're happy, 1 minute you're unhappy.
I guess the only thing I mention is that when you ask about medication, and it's a big problem in addiction and in mental illness, is that we sometimes don't measure for severity of illness. Right. And so it's really hard to measure it sometimes, and people have different phases in their lives. But just to bring in the addiction aspect, I had a friend of mine that years ago who was in recovery, went to AA, and they were put on lithium. And the lithium seemed to really work for him, and it held his manic episodes at minimum. And his complaint about life was that it was boring.
Boring. He liked that mania.
He liked that mania.
Feeling, yeah.
You feel incredible. And usually it's the negative results. You're thousands of dollars in debt. You've acted out inappropriately. You've done, you've run afoul of the legal system. But that whole sense of mania is pretty, reinforcing.
It's intoxicating.
It's intoxicating.
Yeah,
and also you see a lot of substance use during those episodes. Oh, yeah. It's not uncommon for them to, use excessive amount of cocaine and alcohol during those times. So, and I again, I don't know what, there's different medicines that they're using now, and I guess that's in between the doctor and the patient, which one would work best. But definitely I think the biggest problem with medicine and bipolar is compliance, and I think that's true of most illnesses, but especially bipolar.
Right. Yeah. Very few people actually take their medications.
Well, if you're depressed and you take antidepressants and you stop being depressed, because one of the things you tend to do is stop taking them, right. Which for a lot of alcoholics is a mistake, because then they end up relapsing. But that's a separate question.
Yeah. And I think too, and another way that I've seen the bipolar label applied to people is really what let's say is kind of sort of sloppy work or not being thorough enough.
Yeah.
Because people who are struggling with addiction but have not sort of disclosed the addiction, they're going through the sort of use and the withdrawal cycle that they go through, as well as people who've experienced trauma can be very reactive and very troubled. And I think that always needs to be looked at, because you want to get sort of the foundation of what might be going on. Although cause and effect is not always there. I think you need to sort of cast a broader net rather than sort of calling the whole word bipolar anytime you see somebody with a variable mood.
And again, it's information. It's interviewing others, finding more about it. Anyway,
it takes time. It takes time. So that was a great question.
I hope that's all right.
Yeah. If it's not, right back.
Kipling wrote this great short story about, and most of you know about the 7 blind men touching the elephant.
Oh yeah.
And they all touched different parts of the elephant, and they went to describe what an elephant is based on what they were holding, whether it was the tail or their arm or their leg.
Elephant's like a rope. He's like a snake.
Yeah, that's
like
right. And I think in some ways, mental illness sometimes, or alcoholism, or it's almost like what you see at the moment, what's presenting, what is present. Yeah. And so sometimes you need to get a better history, from family, from other providers. And there's an ebb and flow to it too. I mean, I don't think it's always constant.
No.
I mean, you'll see different things at different times. So,
right.
But anyway,
and like with bipolar disorder, there can be different medications for different phases of it.
Yeah.
You're in sort of the what we call the acute mania, or sort of full-blown episode of the mania, versus being in sort of what we call euthymic or normal mood, and versus being depressed as well. So you have sort of maintenance and the acute phase that can cause different medication regimens.
Right, but I would definitely, you should establish a good working relationship with your primary care provider or your prescriber. I mean, I think if you have true bipolar, you need to have a good working relationship with your mental health folks.
And I think there wouldn't be any doubt that you're bipolar if
No.
you're at that far into the spectrum.
That's right.
I mean, so many people have said, "Am I bipolar?" They say so, but I don't really
know.
believe it. So
Right.
that might be a clue to you as well.
Sometimes the evidence has to be overwhelming.
And it takes time to get the evidence too. I've worked with people and had a theory about what's going on, and found out, oh, I'm wrong.
Yeah.
I need to rework this theory if I'm going to be of any help at all. So now, a little more specific question here. This is going to get in the realm of opiate addiction or opiate dependency. And I probably ought to say we've both done a lot of work with opiate dependent patients. And in particular, I've worked with this for a number of years around the medications as well. So this question, is it true that Suboxone is harder to get off of than heroin? I think everybody knows what heroin is, right?
Right.
But maybe this begs a little bit of explanation about what Suboxone is. Maybe I'll try to be quick, but there's two medications that are long-lasting opioids, which, unlike heroin, is a very sort of short-acting and quick. And we think that by putting people on these long-acting medications, that then we'll sort of soothe down the withdrawal and the cravings, and actually help them stabilize to a point where they're not craving, they're not withdrawing, they're not using. But we're also sort of want to keep them awake and productive as well. And I got to tell you, so people often say, "Oh, don't go on methadone. That stuff is damaging. It's murderous, and you'll never get off of it." And they say the same thing about Suboxone. Maybe just today, I was talking to someone who said he wanted to get on methadone because they heard bad things about Suboxone, and the same thing I've heard people talking about Suboxone who then don't want to go on to methadone because of all the bad things they've heard there. But heroin, I don't hear too many people getting off of that by themselves either.
Right.
So I think that it's very much almost like beauty's in the eye of the beholder. Right?
And I think there's expectations, but I mean, quite frankly, it's like welcome to the wonderful world of opiates.
Right.
I mean, this idea is like, well, I'll sniff it, but I won't inject it. I do methadone, but I don't do heroin. I do heroin, but I don't do. It's like it's
I'm
all.
in control.
I mean, it's
I'm
all
in control.
opiates,
Yeah.
and there's no good way to get off opiates. I mean, it's and you have to remember, the Suboxone and methadone are opiates, and so you are taking a prescribed medicine that's an opiate, and it builds up in the system. You get used to being on a certain level of opiates, and when you get ready to get off it, it's difficult. And it's usually the biggest problem, I think, is that most people, when they want to get off a prescribed opioid, they try and do it too rapidly.
Right.
And they really should do it a much slower titration. I mean 6 months sometimes.
Oh,
maybe even longer.
Yeah, even longer.
But I think it's hard to get off any opiates. I mean, and that's what I wish. You can't freeze frame that first moment before you do an opiate to get high. I wish it could. I wish I could show you all the misery that's behind that first pill. All the misery and pain that's behind that first thing. I mean, you cannot even imagine what you're about to do. I mean, you're about to enter into this new world.
You think you know.
And getting off heroin or getting off anything, it's scary. I mean, you'll wake up one morning and say, "I can't do this anymore. Please give me something. I can't go on this way." And not, and at that point, somebody, if you're lucky, you can get into a methadone program. You can get into a Suboxone program, and stabilize your life and get better.
And I think that's sort of inherent in this question as well is the stigmas behind this.
Yeah.
The idea that you have to come off of that once you come onto it. We wouldn't be talking about this if we were talking about blood pressure or diabetes. Nobody would press you to get off that medication. And so we know from experience that some people might be candidates for a lifetime of one of these medications.
All right.
Yeah.
And this has been a wonderful experience. I must tell you, we were very nervous doing this. We were kind of worried about it.
People actually called.
Yeah, well, we've run out of family and friends, so we need. We're hoping that this will be something that people will use. We'll be next on in 2 weeks. Thank you all very much.
Yeah, good evening. Thank you.